Good day, and welcome to the CSAT CTN webinar, Adolescent Youth Projects Updates. At this time, all participants are in a listen-only mode. Later, you will have the opportunity to ask questions during the Q&A segment. Please note this call is being recorded. At this time, I would like to turn the call over to Dr. Lisa Marsh. Dr. Marsh, please go ahead.
Great, thank you. Hi, hello, everyone. This is Lisa Marsh, and I'm with the Northeast node of NIDA's Clinical Trials Network, and I would like to welcome you to our second webinar between SAMHSA's Center for Substance Abuse Treatment and the NIDA CTN. And I'll be facilitating our discussion today. And today's theme is on adolescents and youth. And for those of you who may not be aware, this is our second in a series of CSAT CTN webinars. We had our first one on the theme of implementation research. This one is focused on adolescents, and we have an upcoming session in December on pregnant and parenting moms with substance use disorders. And the goal of this series is not only to review the state of the science as related to these different themes, and we have the privilege of having expert speakers on each of these panels, but also the sort of bigger goal is really to explore potential opportunities for collaboration between CSAT and CTN. As we think about the mission of each of these institutes and points of intersection, we really want to have opportunity for brainstorming discussions and suggestions from this group about ways that we can work together, and either as related to the theme on adolescence, as we're talking about today, or on a broader array of issues. And so that's what we hope to do as part of this series, and including at the end of the panel today as part of our Q&A. We'd like to get into some of that detail. So I'm going to start by briefly introducing our first speaker, which is Dr. Kimberly Johnson. And folks that joined last time also heard Dr. Johnson talk about her still new role as the director of the Center for Substance Abuse Treatment at SAMHSA. And today she's going to start us off with a brief overview about the current state of adolescent services at CSAT. So,
Great,
Dr. Johnson.
Thanks, Lisa.
Sure.
I'm going to jump ahead a couple of slides, and then I changed my order of things for, after I sent the slides in this morning. So I wanted to start by just talking about our discretionary portfolio in general and how we use it. And I do want to point out that our discretionary portfolio is strongly affected by Congress and its whims. But we try to use it. The goal of the discretionary portfolio is to design funding opportunities that move the system through the innovation process so that new ideas are tested by funding programs where we learn about implementation issues in the process of adoption. And as we become more confident in the models, we try to move towards funding systems. So instead of individual programs, move towards funding systems like states or tribal systems to adopt specific practices or to address specific issues or populations. And as we learn how to scale those programs from funding systems work, we can share those identified strategies with other systems. And so we use our surveillance systems like NISDA, NOMS, and even GIPRA to provide the data to assess our success, and program evaluation to help identify process improvements and barriers and facilitators to access to quality care. And so this is really the model for how we use the discretionary portfolio at SAMHSA. And I just want to give an example that's relevant today. So if we look at, this is NISDA data, and you can see that over the past, if it's 13 years now, that if you look at that bottom line, which is 12 to 17-year-olds, that alcohol use has basically been cut in half for adolescents. Well, it's remained relatively steady for older people. And, following that, we had a pretty strong reduction in both adolescent and young adult alcohol use disorder. And so what we know is that there are lower rates of alcohol use disorder in this cohort. So there are actually fewer young people that need treatment, since alcohol is by far the greatest drug of abuse. So what we don't know from this data is that if the population of people who enter treatment are any different from past cohorts, for the drugs of choice and severity at treatment entry, or other comorbidities which determine what treatment is that people need. So we need to look at other data like NOMs that might provide clues about how people that have entered treatment. What we do know, and I don't have slides for this, but we will talk about this more, the other speakers will talk more about this, is that we have had an increase in opioid use disorder in this age group as well as other age groups. And so the treatment needs probably are different. Oops. Okay. So we have youth focus on youth in many of our programs. We have in our homelessness grants, and our HIV grants, and our drug courts, and our ASPR, they all have youth components or grants that are funded that focus primarily on youth. But I want today to talk mostly about our one initiative that is specifically, the whole initiative is focused on youth, and that's the State Youth Treatment Initiative. It provides grants to states, territories, and tribes, and the purpose is to work with providers to deliver treatment and recovery support services to youth with substance use disorders and to enhance or develop state infrastructure. Excuse me, you can tell probably from my voice that I'm not feeling too great. We have, over the last 4 years, we've funded 4 cohorts totaling 50 awards of $250 to $1 million in 36 states, territories, and tribes. And here is a map. Obviously the states are the colors of the various cohorts, and the dots are the tribes that were funded. So some of the accomplishments that we've had in this particular program over a pretty short period of time is we've served 5,600 youth. They've used various evidence-based practices, and that's one of the things about this program is that because we're funding at the state level, they get to choose. They have used multiple programs like adolescent community reinforcement, interactive journaling, MET, and 7 challenges. They've integrated primary care and behavioral care. They're addressing reimbursement rates within Medicaid. They're increasing access to MAT and using technology. I think one of the major accomplishments that we've seen is changes in financing at the state level, particularly with Medicaid, and reimbursing for services in various locations like schools, or doing different term reimbursement strategies, and using EPSDT, which I think has been inadequately used for substance use disorders in states for many years. We've addressed workforce issues such as identifying state youth coordinator positions. So we've had, in other grant programs, we've had women's coordinator positions or the SOTAs, but we haven't, many states have not had youth coordinators, but that was a requirement of this grant program. So I'm not going to go through all of these, but I will say a couple other things that we've accomplished in this grant program is NASADAD has an adolescent treatment guidelines, which was created primarily by the state youth coordinators that were funded by this program. And so now there are guidelines to be used by all states about adolescent treatment. So I want to talk about the challenges because I think that that is the most relevant thing for this group that I want to talk about. And some of it is I'll just read them. So with the evidence-based practices, so some of the challenges come out of the evidence-based practices themselves. We have lengthy assessment tools that people don't use because they take too long, and so they're using screening tools instead of assessment tools, which may or may not be a problem, but it's an issue in terms of people's unwillingness to use those tools. While we can get adoption of the evidence-based practices and the particular programs within the states that are funded under this project, less successful in wide-scale adoption of evidence-based practices. And some of the reasons for that are that they're actually not easy to train. And so, I mean, these are things you guys all know already. So staff turnover is high in specialty treatment programs, and so training has to be ongoing, and that increases the costs, and people are reluctant to do that. And there are issues with using the evidence-based practices within the electronic health record system. So those are sort of systemic kinds of issues. The other kinds of issues that we encounter is most of the evidence-based practices require family involvement, and family involvement is not always practical or possible. And particularly that's particularly true for transition age youth. And family support organizations, which are often engaged, are still mental health focused and don't necessarily have expertise in substance use disorders. We require financial mapping in this grant program, and if you don't know what that means, basically we're asking the state or the territory or the tribe to basically identify all the resources that are being spent on these services and where they're coming from, and all the possible resources that could be spent and what isn't being used. And our incredibly complex funding environment actually makes that a difficult task to accomplish. And we still don't necessarily have parity in coverage. So a couple questions I want to leave us with as we go on to the next presentation, and if you can remember it when we get to the discussion portion, is so what new knowledge about adolescent substance use disorders and recovery should be incorporated into our programs, which I think we'll get some of that today. But then the other critical question from my perspective is, how do we address these issues that are in the previous slides? Can we develop interventions that the current workforce can implement, or do we need to rethink the workforce? And if so, what would that look like? And I think I'm done, and we're on to the next presentation. Thank you.
Great. Thank you very much, Kim. We're going to ask that we hold questions until the end just so we have time for each of the speakers. So we'd like to move now to Dr. Mark Fishman. And Dr. Fishman is board certified in addiction psychiatry and addiction medicine. He's part of the psychiatry faculty at Johns Hopkins University School of Medicine. He's the medical director of Maryland Treatment Centers, and he's a research faculty member at Friends Research Institute. And he leads the Maryland Treatment Centers, which is a regional behavioral health care provider, and it includes Mountain Manor Treatment Center in Baltimore for adolescents. They also have a number of programs for adults and several inpatient and outpatient programs. And in this role, he's been involved in developing and implementing a wide array of innovative programming in addiction and co-occurring disorder treatment. And his clinical specialties include treatment of drug-involved and dual diagnosis adolescents, opioid dependence in adolescents and adults, and addiction with comorbid pain. And his research work has focused on models of care and treatment outcomes in adolescent addictions, particularly opioid addiction. And today, that's what he's going to be talking about. He's going to talk about updates on opioid use disorder treatment for youth. So, Mark?
Well, thank you, Lisa. So I'm going to, as Lisa said, focus on opiate addiction in youth, both adolescents and young adults. It's difficult to know, where the dimensional merge of young people kind of ends, and whether adolescence goes till 18 or 25 or 45 these days, but considering broadly the developmental needs of youth. And I'm going to focus particularly on the role of pharmacotherapies, that is relapse prevention medications or medication-assisted treatment, not because it's the only ingredient, but because it's an important one, and that's perhaps where most of our work has been done, and it looks like an emerging area where we're getting an increasing signal that there's effectiveness. You heard Dr. Johnson talk about evidence-based practices and the importance of both disseminating them from a scientific point of view, but also from a logistical, practical point of view. In this particular field of specialty treatment for youth with opioid addiction, we don't have the same evidence base that we perhaps have in other areas of youth treatment, say with cannabis, with alcohol. So it's The evidence that we'll talk about today is more on the emerging side, but it's really also important to emphasize as we go forward the point that Dr. Johnson made about implementation and practicality and the movement from research and science to the community under standard public sector kinds of reimbursement models, because that's where the rubber hits the road. So I'm not going to spend a lot of time talking about the scope of the problem. Everybody knows. It's even not necessarily just in the specialty journals, but it's in the newspapers, this issue of the current scourge of the opioid epidemic. Just a few words about youth. Opioid addiction, as it's been such a problem in this country, disproportionately affects youth. There's a greater absolute number of older adults involved just because of the demographics, but in terms of per capita proportion, it's a disproportionate involvement, especially of young adults, both for prescription opioids and for heroin. The good news is that the trend of recent years' increase in prescription opiate use looks like it's starting to level off, but the heroin increases of the past decade, 2 decades, are going up and up with no end in sight. Another important issue to think about is that although use and addiction rates are escalating, deaths from overdose are actually escalating in advance of use and addiction rates disproportionately. So there's higher potency, there's more dangerous use, and there's, in this epidemic, more people dying. Next slide, please. I'm going to jump to just a frame of a difficult case to highlight some of the issues that are different developmentally in young people compared to their counterparts older in the lifespan. The issue that youth are not just short adults. That's old news in youth treatment, but it's also very important in opioid treatment. This is an 18-year-old young man who's been using prescription opioids since 15, progressing quickly to daily use with full physiological dependence and withdrawal, then to nasal heroin, and then shortly to injection heroin. That's not the only trajectory, but it's a fairly typical one, and it illustrates the progression in that order with the different routes of delivery and also the condensed time frame for how accelerated it is with the pharmacological properties and addictiveness of opiates. Also illustrative here is the emergence of a high severity group of youth with high utilization and multiple bouts of treatment. Not so surprising in what we know in adults is a remitting, relapsing illness with a circuitous course. He's had 3 episodes of residential treatment. 2 of them he's left prematurely. 1 he completed but didn't keep the recommendation for prescribed and scheduled ongoing continuing care. He has had 1 outpatient treatment episode with buprenorphine, but it didn't go so well. He met a physician who said, "Oh, you're an opioid addict. Here's a month's worth of buprenorphine and 4 refills and have a nice life." That didn't exactly go so well. He took it erratically, sold half of it, continued to use heroin, and wasn't exactly the poster child for the success of buprenorphine that we would hope for. And I don't mean to trivialize suffering or to disparage treatment. It's just to illustrate that the recipe in some circumstances remains elusive for us. Here he comes again in a new crisis, in a series of many, and says, "I really mean it this time, Doc. I want to come into inpatient detox. I'm ready to do anything you say. I understand how I maybe didn't do this right before, but now I'm really in all the way. But, you know, I'm kind of in a rush, and I'd really like to get this over quickly. Can I be out of here by Friday? There's a good party I know about I need to go on Saturday. And by the way, I'm allergic to Suboxone. It needs to be Subutex. And by the way, did I tell you about the Xanax I'm prescribed?" And on, again, not to trivialize suffering, but to say that there are these barriers to treatment engagement adherence that whatever we decide about the effectiveness of any evidence-based model, including pharmacotherapy, the issue of engagement, the issue of retention, the issue of delivery and working with youth, remains paramount. Next slide. So it's no surprise to people who work with young people that there are many developmental issues that need to be navigated. Young people tend to see themselves as invincible. There's the obvious kinds of difficulties of immaturity and lack of full development of executive function and half-baked frontal lobes. And there's an additional, I think, disproportionate salience to young people of the burdens of treatment. We ask a lot of people in treatment. It's, I think, appropriate because treatment, at least at the outset, tends to do better, we think, with intensity. But this is a big problem for young people who may not find treatment engaging and who find that the barriers, we at this one hand want them to do treatment and focus on that above all else. On the other hand, we appropriately want them to engage in pro-social, rehabilitative reemergence into the rest of life, and sometimes those things are in conflict and they may not want to do as much as we ask them. Families are important, as I'll talk about later, and there's a whole host of variability to the effectiveness of family leverage, whether they're involved, whether they're not, even to the point that some families may be abdicated. Dr. Johnson mentioned that sometimes it's impractical to include families that don't want to be involved. And particularly young adults, certainly adolescents, but particularly young adults, have a what is developmentally normative and appropriate pushback against their sense of over-involvement of parents and a sense of parents want them to be dependent. Treatment providers may want to involve parents, but they see that as overly restrictive, and this pushback that on the one hand may be normative but is problematic. And can't emphasize enough, although I won't spend a lot of time talking about it, that comorbidity with a lot of different other psychiatric issues are very, very common in youth, and if we don't address them, we're not going to make progress. Next slide, please. So I'm going to go through a little bit of the state of the science, just a quick review. I won't show everything. One thing that makes it easier is that there isn't as much work as we hope. In fact, there's relatively little work, but I'm just going to show you some highlights. This first is a consolidation of 3 different papers talking about residential treatment. All of these come out of either historical era or of a paradigm when medications were not prominently used. On the upper left-hand corner, this is looking at the outcomes of opiate-involved youth following an index episode of residential treatment, heroin users compared to non-heroin users, short-term residential treatment of, say, 3 or 4 weeks, and then looking at them over time out to a year. And although the good news is that there is substantial reduction in amounts of use compared to the non-heroin users at all time points, they have higher severity, they don't respond as well, and they relapse more. That won't be so surprising, I suppose, but it's important to document that it's got a different level of severity compared to alcohol and cannabis-only users. On the right-hand side, though, again, there is some ongoing improvement that happens over time, and at 12 months, this is in the same cohort, some, unfortunately small, but nevertheless meaningful proportion of these patients had last 90-day abstinence, but of course, many of them relapsed. And in the more recent study led by Zev Schumann-Olivier, and John Kelly was involved in this group up in Boston, looking at outcomes from a Minnesota residential center, looking just at how people do over the course of a year. And opiate patients did reasonably well, but it's a glass half empty, half full. And their outcomes were not that dissimilar, but somewhat worse than non-opiate users. And one of the things that was characteristic was that they had greater rates of inpatient return with need for repeated detox and greater utilization of outpatient. And that's probably a marker of severity rather than a marker of engagement. So there's a baseline. There's a role for residential treatment. It helps, but it doesn't seem to help enough, and the rates of relapse and the engagement in continuing care post-residential treatment is alarmingly low. Next slide. So this really is an illustration of what is still the seminal work in the field. This is George Woody's CTN10 trial, a multi-site center trial of buprenorphine versus control in adolescents and young adults. And the bottom line is this is essentially a proof of concept that buprenorphine is effective at treating this population. Patients were randomized to a 12-week course of treatment with buprenorphine plus psychosocial treatment versus detox plus psychosocial treatment without ongoing buprenorphine support. And here you see the closed black circles compared to the open white circles, which are the controls. South is good because it's a measure of opioid-positive urines. And during the time that patients are on buprenorphine, they have lower rates of opioid-positive urines when they come off of the treatment, tapered at 9 and then stopped at 12 weeks, you see a return to the control. And so again, a proof of concept in an ABA fashion that on medicine rates of use are lower, off medicine they escalate to background and to control again. Unfortunately, 12 weeks is a very short amount of time in the life or career of a youth with a severe substance use problem. So the question remains how to go from this demonstration in boutique research with small caseloads and special NIDA funding to thinking about what does it look like in the real world in the clinic. Next slide, a couple of important secondary analyses of that data set, looking at predictors of retention, looking at predictors of abstinence, mostly expected findings, but a couple of surprises, but still very, very important to know because we want to be able to think about how you would stage. Some people do well, but as you remember, although the numbers of opioid-positive urines decreased dramatically and in a clinic, both statistically significant and clinically meaningful kind of way, they never went to zero. So how do we find out who's going to do well and perhaps change in a staged way interventions early on based on treatment response? So it looks like early adherence to medication, early results of treatment with opioid-negative urines, having concurrent medication treatment for psychiatric illness, having psychiatric illness probably as a marker for a disorder that is amenable to additional treatment, all seem to be indicators of doing well. Next slide. For a little glimpse of real-world treatment, this is work from Steve Mattson in Columbus, Ohio, where he runs a outpatient clinic connected to an inpatient pediatric unit in a general pediatric hospital. So patients come in, get detoxification, and then continue in a hospital-affiliated outpatient clinic. And this was the first report of looking at kind of real-world or semi-real-world, still attached to an academic center, but it's not boutique research, and it's standard care. And so looking at what happens over the course of a year in patients treated with buprenorphine. And 60-day retention, about 45%. That's less than we see in most published studies of adults, but half empty, half full. It's still, I think, remarkably good, certainly compared to treatment without medications. Then you look at treatment retention at a year, and you're down to less than 10%. So a lot of dropout with steep attenuation of treatment and treatment engagement over the course of the year. He did a little bit of a look at predictors of retention, saw some of the same things that early opioid-negative results, early buprenorphine-positive results. Imagine that if you take the medicine, it works better. But also an interesting and important result that having a urine drug screen that was negative for cannabis looked like it was predictive of success. That was not a finding in the secondary analyses of the Woody CTN studies, but it remains of great interest, and most clinicians will tell you that they think abstinence more broadly over and above opiate abstinence, but that abstinence from other substances, and cannabis and alcohol presumably being the most prominent as the most widely used, are predictive. Unfortunately, the patients don't always agree with that, and so being able to demonstrate that and look at for whom that's true and for whom that's not true would turn out to be very important, I think. Next slide. This is work from Boston group of Zev, Schumann, Olivier, looking at treatment of young adults in a mixed-age clinic. So this is an adult clinic where they treat everybody, all comers over 18. It's an academically affiliated specialty clinic, but in an internal medicine setting. And the point he makes here is that the emerging adults age 18 to 25 don't do as well as their counterparts further on in the lifespan. In general, both of these groups have fairly good results. You'll see that there's 6-month retention of nearly 40% in the young adult group and 62% in the adult group. 62% is fairly robust for most published studies. But again, it's not as good in adolescents. That is, it's not as good in young adults. So half empty, half full, it's good, but not good enough. So there is some, as you see information about buprenorphine. One of the other medicines that's FDA approved for the treatment of adults, opiate addiction in adults, is extended release naltrexone. So next slide. And if you think there's only a little bit of research about buprenorphine in youth, there's even less, fairly none really, in extended release naltrexone. There's one case report of the first 20 patients that we treated at our center, and we had good feasibility, and about half of them did okay at 4 months, but it's hardly randomized data, and that needs to be explored further. Next slide. Looking at a group of young adults in a different cohort, this is work that we published from a group of young adults in a specialty opioid treatment program, and one of the interesting things here is that our 6-month retention was just about the same as Dr. Schumann-Olivier's 40% at 6 months. And this is in a community treatment program under scant Medicaid nickels, full real world, no additional kind of academic research resources. So the feasibility of being able to engage patients over time is encouraging, again, even though it's not at the rates that perhaps you'd expect in adults. The other thing, although this is naturalistic, non-randomized, small N work, is that at 6 months, patients who were on buprenorphine and patients who were on extended release naltrexone did about the same. This is certainly not powered to make that comparison, and it's non-randomized data, but the point that you can, in a feasible, practical, logistically doable way, have both of these patients, those on bup and those on extended release naltrexone, side by side in the same group with the same counselors, managing together, and both doing relatively well. One thing that's interesting is early on, there might be a hint that extended release naltrexone up to, say, dose 2 or 3 at week 5 or 6 or 7 looks like it's outperforming buprenorphine, but then there's this very steep slide. And so one question that is raised is, if this is reproducible result, is there something that could extend the trajectory of response to extended release naltrexone by increasing retention past dose 3 or 4, where it seems to slide off and people get treatment fatigue? Next slide. Just to show a couple of other comparison points, this is unpublished data from our Baltimore Center looking at young people who come from an inpatient detoxification rehab episode and are referred to ongoing outpatient treatment, looking at rates of initiation of outpatient treatment in step down from inpatient treatment. This is naturalistic, non-randomized data. Even though we have attempted over the years to strongly shift our standard of care so that medications are the prescribed and recommended modality, not everybody agrees, and so a small group of people still choose no medication. And so it looks like the people who choose medication, that is the patients and their families and their clinicians in collaboration, initiate outpatient treatment at a greater rate than those that don't choose medication. Now, again, that doesn't necessarily show that it's a medication effect. It could be some kind of selection bias about the people who decide to follow a treatment team recommendation versus those that don't, but it's still encouraging. And next, this is the same cohort tracked out over 12 weeks, showing that for most of that treatment course, people on medication look like they're retained at a greater rate than those on no medication. This next slide, just to compare the two groups, a small group of people on extended release naltrexone, a small group of people on buprenorphine, again, naturalistic, unrandomized treatment, and the treatment course looks about the same. And some of them drop out. In fact, most of them drop out, and one of the questions that this raises for the future is what, and I keep saying this, what can we do to increase retention rates? Here again, we have somewhere between 20 and 40% retention at 12 weeks, and that's problematic. Next slide. This is Dr. Marsh's work, in which she recently published a study randomizing youngsters to a 28-day course of buprenorphine versus a 56-day course, so 1 month versus 2 months, looking at 2-month treatment engagement and urine results as the outcome. And those that have the longer course of treatment at the end of that course of treatment are doing better than those that have only half as much pharmacological treatment. So the folks that are only on 1 month of treatment don't do as well as those that are on 2 months of treatment. At the 2-month point, that I think confirms our evidence that being on medicines for this population while you're on medicines does better than not being on medicines. But I show this for an additional reason, and it was kind of an accident of the way the study progressed, not so much the intended comparison. When Dr. Marsh's group initially began the research, they were requiring daily participation, daily attendance to get medications, and they were struck by that being a barrier, as I said before, in terms of how patients were adhering or not, dropping out or not. And so partway through the study, they shifted to a somewhat less restrictive model in which 2 to 3 days per week attendance would do rather than daily attendance. And so what you see here, although it's not randomized, it's the beginning of the trial versus the end of the trial. In both circumstances, 2 months better than 1 month, but in general, the average response for the less restrictive, less attendance requirement of treatment is better. And this is really the first study that looks at treatment model or delivery system in a comparative way. Again, it's preliminary, it's not randomized. I'm not sure that this is the most important, but it sure is very important and raises the question, what's the correct balance between intensity? How do you think about treatment fatigue? How do we think about it being a marathon, not a sprint? How do we measure treatment burden and try to engage kids in the long haul, even if our initial notion is they need lots of intensity, they need lots of frequency, they need lots of structure? Yes, all those things are true, but just because they need it, if they won't get it, and in fact, if it's a barrier, then have we done the right thing? So this is another area that needs exploration. So next slide. Just in terms of some conclusions from that brief survey of state of the science, medications, that is relapse prevention medications, MAT, buprenorphine especially, to a lesser extent extended release naltrexone, are feasible and effective, and surely being on buprenorphine in this population is better than not being on buprenorphine. Now that's an old result in adults, but it's really an importantly new result in young people. But the question again is going to be, how do we deliver that? Being on bup longer seems to be better than being on bup shorter. Again, old result in older adults, a newer result in youth. There's a role for residential, and thinking about the intersection of residential treatment with initiation of medications. What a wonderful potential opportunity, and this goes for older adults too, because in neither populations has it become the delivery system standard of care. All of these treatment episodes where people come into detox as an opportunity to initiate them onto medicines for continuing care, so an area that we really haven't taken advantage of. Extended release naltrexone looks promising, but much more work needs to be done, and then there's some promising exploration of moderators and mediators. Next slide. So this is what we've been doing. Other people, including Dr. Levy, who's going to be talking about SBIRT next, and Dr. Matson in Columbus, and others who've chosen to do this difficult work, would probably say some of the same things, that a detox is maybe important, but it's got to lead somewhere. And so the revolving door for a full continuum of care needs to be standard. Treating these young people in a specialty care setting where opiate addiction and its special difficulties are emphasized with a specialty staff, with a specialty program, and also treating them in a youth-specific program where developmentally informed elements can be part of it is important. It's not going to be a surgical or curative model. It has to be a longitudinal model of enduring care with the expectation of remission and relapse, unfortunately, but realistically, for what is a chronic illness for most of these kids. That's old news for adults, but it is radically new news for young adults. And the delivery system nationally really hasn't caught up with shifting from an episodic, discrete model to a longitudinal model. That integration of psychosocial treatment with relapse prevention medicines ought to be the standard of care. That means buprenorphine and extended release naltrexone, as we've talked about. There's very little information about methadone. I won't spend a lot of time talking about that, except to say that it's really perhaps more about the delivery model for a youth-specific delivery rather than it is the molecule. and that co-occurring or dual diagnosis treatment really ought to be part of the integrated fabric of what that is. Next slide. So there are some tensions in these emerging models, and each of these form the basis of potential questions in terms of treatment delivery and in terms of research. What's the role of treatment matching and individual patient-centered care, and should that have to do with stages of severity? Should the contemplative youngsters be in the same program and in the same groups as those that are further along in their stages of change towards action? And it's sometimes difficult to blend those groups, but it's also difficult to separate them, so that remains an issue. Are there different approaches for different levels of severity? And that also brings up the issue of intensity and structure versus reduction of burden and accessibility, as we talked about, where treatment fatigue, both early on and then with enduring treatment as people start to have success, what are the markers that let us know that we can decrease intensity, decrease restrictiveness, and still have people do well? This issue of what about the role of other substance use? Because our medicines now are very narrow spectrum. They're opiate specific only. They work only at the opioid mu receptor, either as a partial agonist, buprenorphine, or a full antagonist, naltrexone. But the issue of enduring, persistent, or sporadic use of other intoxicants, most prevalently cannabis and alcohol. Most of the patients that we treat start out pretty pre-contemplative about their marijuana use. It's not a drug, it's a medicine. Everybody uses it. What's the big deal? I came here for treatment of my injection heroin use. Aren't you glad that I'm not doing that anymore? What's the big deal that I'm intoxicated all day, every day on cannabis? It's what I need to cure my anxiety, Dr. Fishman, leave me alone. So what's the role there? How do we relate to patients about that? Is there an importance of intensive intervention early, or is incremental improvement over time the appropriate approach, and how to do that? And then this issue, lastly, of parental involvement versus youth autonomy. Just to spend a moment on it, we have the notion that parents can be a very powerful tool and a very powerful force for engagement, monitoring, leverage, but how to use it appropriately remains a big issue. And as I said before, youth tend to push back against it. Just a joke, lots of parents may not be available, but there's also lots of parents who knock on our door and get the sense that they're not welcome, and they get yet another speech about enabling. In fact, sometimes they drop their kids off for treatment and then call back to discuss with the counselor, how's little Johnny doing, and they get the recording or the rote speech that says, we can neither affirm nor deny that a person of that name is receiving treatment at this facility, and can you call back to me? So that's discouraging to those parents that are interested. And so I think that there's a lot, next slide, I think there's a lot of work that can be done with developing a framework for family engagement. You heard Dr. Johnson say that family involvement is an important part of much of what we do in evidence-based treatment, in other youth treatment. How to incorporate it into youth opioid treatment, especially in young adults, where the young adults say, I'm 18 now for an hour, and that means I'm all grown up, and I don't need my mom and dad, and you can't tell me what to do. So thinking about a recipe for roles, treatment expectations, and responsibilities. And it looks like I'm out of time, so I'm going to run to the second to last slide, number 20, and just give you a list here of questions to move the field forward. This is incomplete for sure, but I think it's a good start. These are all issues and questions that could be fertile ground for further research, for further exploration of clinical treatment models, for further exploration of practical logistics for delivery. If we think that medicines are important and effective, well, what are the optimal models for delivering them? If we think that medicines are effective, how do we improve adherence? I think I showed you that we've got good results, but not nearly good enough results, and retention and adherence are major issues. What are hypotheses that we could test about treatment matching, and what are the sequencing and branch points to shift the trajectory of treatment for different trajectories of treatment response? I think there's a huge role for both research and clinical exploration of additional supports that these young people need, whether it's enhancing the involvement of families, whether it's thinking about the appropriate role of residential supports, because there are a group of these very high severity patients who have unstable housing situations. They may be homeless or pseudo-homeless. Their parents may have kicked them out and been fed up. And what are the long-term residential supports? We think about recovery housing as an element of the treatment continuum and residential support services for adults, but that adult model doesn't really fit young adults. It doesn't have enough supports. It doesn't have enough vocational and educational and structural monitoring, so something to be done. And then Dr. Johnson mentioned models like ACRA, the Adolescent Community Reinforcement approach, where with cannabis and alcohol we have good evidence for the role of assertive outreach and even home-based treatments. Could those have roles as additional supports? And then lastly, just to conclude, and this will lead into Dr. Levy's talk about SBIRT, we've done a pretty terrible job, I think, about catching patients outside of the specialty SUD system. And so how do we learn about broader patient touch points where the patients are before they knock on my door, in general health care, in the emergency department, in primary care, in hospitals, and in juvenile justice? So next slide, just a last cartoon. If only it were about doing a mu receptor ectomy or otomy, or if it only were all about finding the penicillin to cure youth opiate addiction. Not that we've done it, but boy, that would be a lot easier, but it's certainly not that easy. And young people are difficult and have their own, as I've said, developmental issues that require, I think, us learning about specialty techniques for engagement, and so lots of work to be done. And I'll quit.
Okay, terrific. Thanks so much, Mark. That was a great presentation, and it really generates a lot of questions for discussion among this group. But before we do that, we want to move to our third and final speaker, which is Dr. Sharon Levy. And Dr. Levy is a board-certified developmental behavioral pediatrician. She's also an associate professor of pediatrics at Harvard Medical School. She directs the Adolescent Substance Abuse Program in the Division of Developmental Medicine at Boston Children's Hospital, which is comprised of clinical research training and policy arms. And she's currently co-PI of a SAMHSA-funded adolescent SBIRT project, an NIAAA-funded study validating the youth alcohol screening tool in a population of youth with chronic medical illness, and a Conrad and Hilton-funded study that aims to validate adolescent SBIRT measures and test a brief intervention for medically vulnerable youth. And so today she's going to give us an update on screening and interventions in pediatric medical settings. Sharon?
Thank you. So we're really going to switch gears here now and talk about brief interventions with adolescents and look at the database. And I think the one thing that this presentation has in common with the previous one is that there's an emerging evidence base. There's not as much as we'd like for any of these tools that I'm going to discuss and talk about today. So first, I just want to start out with a definition of what we mean by brief intervention. I think that the nomenclature has been very inconsistent within the field. Brief intervention, when we're talking about adults, is really typically a discussion of a conversation that's meant to reduce alcohol use in patients who have screened as positive for high-risk or at-risk drinking. And when we adapted the concept of SBIRT to adolescents, we wanted to think more broadly and use the opportunity to deliver prevention messages to kids who had not yet initiated substance use, or to very sporadic users who we thought may be early in some sort of trajectory. But that has caused, I think, some confusion in what we mean by BI. So for the context of this particular review of the evidence, I wanted to focus a little bit more tightly and define brief intervention as a conversation between a professional and a patient. It's often a primary care provider, but it doesn't need to be. It could be an allied mental health or behavioral health provider. These generally occur in general medical settings, So it's often in primary care, but there have been studies certainly looking at brief interventions in emergency departments and some in subspecialty medical care. I have excluded, though, for this presentation, brief interventions that have been tested in psychiatry settings because typically the visits and the intensity are much, much longer than in other medical type settings, and so they look a little bit different. I didn't want to mix them all together. Brief interventions are typically incorporated into a routine visit. So a patient will come for health maintenance visit and get a brief intervention as part of that visit, or will present for an urgent care appointment or perhaps in the emergency room and have the brief intervention incorporated rather than having a special appointment just to have a counseling session. In the definition that I'm using or proposing today, brief intervention is going to include some sort of negotiation or planning, and the aim is to reduce substance use and or increase acceptance of a referral to more specialized treatment. And this definition is consistent with the American Academy of Pediatrics expert guidelines, which were published last July. So although there's a recommendation for an intervention at every screening, for every screening response, what we call brief intervention is reserved for describing the response to those with mild, moderate, or severe substance use disorder. Just to point out, so what is not included in brief intervention, so I'm not going to be looking today at what's commonly called brief advice or sometimes called anticipatory guidance. So these are prevention messages delivered to non-users or low-risk users. I will not include interventions delivered in subspecialty substance use disorder care, even though sometimes those interventions are called brief interventions, and I am not including interventions in psychiatric care. I will include electronic interventions. However, I'm going to do a separate section on them. So I'd like to start with first with the InPerson VI models. And there are really three that have been developed, described, and tested and reported on in the literature. So the first is the brief negotiated interview. That's based on motivational interviewing. The second is a model called the 5 A's. And the third is a model called Project Chat, and I'll go through them one by one. I'll start with the brief negotiated interview, which was developed and named by the folks at Boston Medical Center, predominantly under Ed Bernstein. And the BNI is a structured intervention comprised of 5 steps. They're all based on motivational interviewing. So what Dr. Bernstein did was he took this idea of motivational interviewing and he made it into a very tightly structured intervention called the BNI. He added to that the sharing of information and offering advice, which may or may not be a part of traditional motivational interviewing. But it's distinct from motivational interviewing in that it's a highly structured intervention. There are 5 steps that are walked through, typically in order. I'm showing you the steps here, and you can see for each of these steps there are some strategies, and the strategies are pretty much all taken from the motivational interviewing handbook. So in the initial work on the BNI, the researchers recruited a group of 60 youth aged 14 to 21 in a pediatric emergency department, and they were looking for kids who had high-risk alcohol use by one of a couple of different measures. Either they had experienced consequences related to drinking or they received a certain cutoff on the audit. And this was a qualitative study. The youth all received the BNI, which at the time was about 30 minutes, and then they participated in a 60-minute follow-up interview. And really what they found was that interviewees could be divided into 2 groups. They called them chillers and copers, and the chillers were youth who were drinking for social motives. They saw drinking as a way to relax, as a way to have a good time with friends. And then there were copers who were drinking to relieve stress or had to fill in for other sources of social engagement. And this group tended to be less goal-oriented. And I think what was important about this study is that by understanding chillers versus copers, they were able to cut the BNI down from something that took about 30 minutes, which would really be, I think, pushing the time limit beyond a comfortable boundary for most general medical settings, into something that was closer to 10 to 20 minutes, which is more realistic, probably gets it just a little bit more into the time frame that could be acceptable. So the second study that was published was called Reaching Adolescence for Prevention. Again, it was youth aged 14 to 21 coming to a pediatric emergency room for the same types of problems, at-risk alcohol use or binge drinking or high-risk behaviors or problems or high score on the audit test. And in this study, they recruited 858 individuals and randomized them into 3 groups so that they could look at intervention versus usual care, so no intervention with a standard assessment, and then no intervention with a minimal assessment, just to ensure that they were not having their results clouded by assessment reactivity. And this is a slide showing us their results. So what you can see is that at 3 months, kids who got the intervention, well, let me just say, I'm sorry, that the 2 control groups looked exactly the same, and so they were combined in the analyses. And so we really only have intervention compared to control. And at 3 months, the youth who had got the intervention were more likely to report that they had tried to cut back on drinking, that they had tried to quit drinking, and that they were trying to be careful about situations they got into during drinking. Now, those were predominantly held until 12 months. The only one that didn't hold at the 12-month mark was cutting back on drinking, in which case the confidence interval just barely but crossed 1, and so there was some fading of that result over time, although you can see that the attempt to quit, not to cut back, but to quit, was still robust at 12 months. And this second set from of studies from the same research group was looking at an adapted BNI. So this is a much shorter BNI, 5 to 10 minutes, and was adjusted for the context of drinking or drinking habits. So again, it was looking at separating chillers from copers. So they actually made the steps a little bit more brief and cut out some of the tools to make the intervention a bit shorter. And they enrolled for this one, again, same 14 to 20-year-olds with risky alcohol use. This time there were 149. Same groups, intervention, assessed control, and then minimally assessed control. And they were surveyed at baseline 3 months and 12 months. And what they saw this time was that this was a much smaller study, so harder to get significant results. They didn't really see anything looking at reports of marijuana. I'm sorry, this was looking at high-risk alcohol use or marijuana. This was looking at youth with no alcohol use, but with high-risk marijuana use, with this brief intervention. And what they really saw, and this was really very interesting, is very different from the alcohol results, is that the intervention group were, in fact, more likely to report abstinence at the 12-month period, but they didn't see any effect at the 3 months. So it seemed like the intervention had an effect, although the effect really took some time, even well after the intervention was given, to have its fullest effect. So this is very different. So in alcohol, we saw that the effect was early on and faded a little bit over time. And with marijuana, it may have been that the intervention was still kind of with them, was resonating with them over time, and really took a longer time to flourish. Here is looking at the data. You can see that the control group is in red there and didn't really have much change in their mean use of marijuana days over the 12-month period, but the intervention group, you can see, has a slow, steady decrease over time. Okay, the next model I want to talk about is the 5 A's. So this is an intervention that's comprised also of 5 steps, and it was initially developed for addressing tobacco use. What's really significantly different about the 5 A's is that there's in the traditional 5 A's approach, there's not much of an educational component, right? And there's not much of a discussion about, typically there's not a whole lot of discussion about the harms of tobacco use, nor is there a lot of time spent trying to develop the discrepancy for the user, or thinking about what the personal harms might be. And I'm going to show you the results in a moment. There have been a couple of studies that have shown that this is a pretty effective tool for reducing tobacco use. But what's very interesting is that it seems to me that this intervention really assumes a baseline understanding on the part of kids who are coming in and receiving the intervention that tobacco is bad for health. And I think that is an assumption that we can take for granted. It's certainly been my clinical experience, and I think the experience of many others, that the public health messaging on tobacco has really been so good that typically we don't need to convince kids that tobacco is harmful, and so that the intervention can take a little bit of a different shape. And so here are the 5 A's. You can see that it starts simply by asking, which is really just the screen, and you move right from ask to advise. From if you are smoking, I really have to tell you that smoking is bad for your health, and figure out if they're ready to quit without much in between. And there have been 2 pretty big studies of the 5 A's. The first one was done in high schools using a cluster randomized design with 35 schools that were stratified for school size, looking at adolescents in grades 9 through 12 who reported past day smoking and interest in quitting. So in some regards, this was not exactly a treatment-seeking group, but a group that was amenable to treatment. There were over 1,000 kids who were recruited and randomly assigned either to the 5 A's or a separate intervention, each comprised of 4 nurse visits, and they were surveyed at baseline 3 months and 12 months. And here are the results. And you could see that the solid line are the kids who got the intervention, and the dotted line are the kids who received the control. And so the reported quit rates were better in the intervention group. And you can see in the table data that if you looked at abstinence from tobacco, it was better in the intervention group. And also the amount of cigarettes smoked and smoking frequency were both lower in the intervention group, so a positive result here. There was another trial that was very interesting. It was using the 5 A's with teenagers aged 13 to 17. It's another cluster design trial with 8 pediatric primary care centers. And in this group, they recruited both smokers and non-smokers, so they did both a brief intervention as we've defined it. They've also did some preventive messaging. They recruited nearly 2,700 kids, And the 5 A's model was actually broken up. So the provider did the screening and did the assessment of how ready the kids were to make a quick attempt, and also made the referral to a peer counselor, who then went ahead and advised the kids and arranged for some follow-up. So the intervention was actually split between 2 providers. And here are the results. And what's really interesting is that the non-smokers responded well to the preventive intervention with statistically significant differences in abstinence rates over a 12-month period. But the smokers actually did well at the 6-month point, so they were more likely to be abstinent, but though that data crossed by 12 months, and so the effect was lost. And then the third in-person model is Project Chat, and this was developed by Liz D'Amico and her team out in Los Angeles. This is a structured intervention that's comprised of 3 steps, largely based on motivational interviewing. What's a little bit different in this model is delivered by a health educator after a handoff from another clinician, usually a primary care clinician. And this intervention was developed with community-based participatory research that involved clinical staff, parents, and adolescents. And in the first phases, they did a lot of qualitative work. And what they really found was that both patients, adolescent patients, and parents were much more amenable to receiving an intervention and had many more questions about substance use than the providers had anticipated. So they were able to feed this back to the providers who were participating, and I think that that made an important difference. And here's a theoretic model that I won't belabor of how they built the intervention. And just to summarize it, the intervention is comprised of 3 parts that are to assess the motivation to change, to enhance motivation to change, and then to make a plan to change. And the goals are obviously to help adolescents make healthier choices, but at the same time to minimize PCP burden and to honor adolescent parent and provider choices based on what was learned in the first set of studies. This was tested in a community-based healthcare organization. They enrolled 42 kids aged 12 to 18 who were considered high risk because of reports of alcohol consumption or drug use. They were all randomized to Project Chat or usual control, and they were assessed with a CRAFT, an alcohol and drug use questionnaire, and they also received post-intervention feedback interview. And here are the results. You could see that both alcohol and marijuana use rates were lower in the intervention group, those who got Project Chat. Again, this is a fairly small sample. The alcohol, although that looks robust in the graphs, didn't quite meet statistical significance, even though they saw an effect size of about 0.47. However, the marijuana decreases were statistically significant, so they did have a significant effect on reducing marijuana use. And at 3 months, you could see that the reduction was about 80%. The effect size was about a 20% reduction in the times used marijuana in the control group, in the intervention group. I'm sorry. Now I want to just switch gears, and I realize that time is fleeting, so I will go through this quickly. But there have been a number of technology-based brief interventions developed and studied, and this was one overall study that
looked at kids 13 to 17-year-olds who were coming into a pediatric emergency room and looking at their preferences for how they would like to receive a brief intervention. And of those who reported a risky behavior, 85% of them were interested in receiving a brief intervention. And of those who reported risky behavior and said that they were interested in receiving a brief intervention, half of them said that they would interested in or prefer a technology-based intervention. So there is certainly a market for this in terms of teen preferences, and obviously there's a real efficiency, there's a scalability in this model, and it doesn't take a lot of provider time, so there is real reason to think about building these models up. The first one I want to show you is one called Head On. This is actually developed by Dr. Marc, and this is an interactive substance use prevention program. So this is the looking for kids in grades 6 to 8. This was administered in school actually. They received 15 sessions during the academic year, each 30 to 45 minutes, and this was compared to a life skills training program that had been previously studied and shown to be effective. And in a nutshell, both groups had some changes, but the head-on group had improved knowledge compared to the life skills teacher-taught curriculum. And this is just showing the results that looking at actually reports of alcohol use and kids' perceptions of others using cigarettes, alcohol, and marijuana were all better in the kids who got the head-on program. There's an intervention called Safer Teens that was looking at was looking at brief interventions delivered in emergency room, and here this was a head-on trial of computer versus therapist, and it was a complicated design with or without a post-emergency room follow-up session. So the researchers recruited a group of youth aged 14 to 20 who screened positive for risky drinking. There were a total of 836 in the study group, and they were randomized to get either a computerized BI, a therapist BI, or a control BI. And the reports of this one, you can see that regardless of, at 3 months, regardless of whether the BI was delivered by the therapist or computer, everybody who got the BI was doing better than the control. That remained true for alcohol consequences at 12 months, that either computer or therapist BI was better than control. And in a similar study looking at brief intervention for cannabis that enrolled 12 to 18-year-olds with past year reports of cannabis use, with the same sort of stratified design where they either got a computer-based or therapist-based intervention and controlled, and they looked at 3, 6, and 12-month outcomes. The results were a little bit more sporadic. So so kids who got a computer-based intervention had reductions in marijuana use at 3 and 6 months, but that washed out by 12 months. The therapists actually, those who got the therapist-based intervention didn't have any statistically significant reductions in cannabis use at any of the time points. But looking at other drug use frequency, again, at 3 months, the computer-based interventions saw reductions. The other groups saw reductions, but they were not statistically significant because other drug use is a fairly uncommon event. What was really interesting was that the alcohol use, looking at alcohol use severity, 6-month follow-up, there was statistically significant reductions in those who got the therapist-administered BI, but not in the computer delivered BI. So there were real differences, and although the computer administered BI, the electronic intervention is fixed, so we know everybody got the same thing. There's even with good adherence monitoring and a very structured intervention, I think therapists will always have a little bit of variability in what kids are getting. And I suspect what we're seeing here is that the results are probably tied to what was discussed in the intervention, what was emphasized in the intervention, which at some level was up to the individual therapist to determine. And then finally, there are a number of works in progress. So they're not listed on this slide, but the American Academy of Pediatrics has funding from NIDA to study the 5A's model with youth presenting for primary care pediatrics, but specifically looking at cannabis use. So that's about to hit the field within the next year or so. And there are also a number of electronic interventions that are under development. I've put up here the names of 3, 2 by Dr. Marc, Step Up, which is targeting adolescents with substance use disorders, and POP for Teens, which is targeting prescription opioid misuse, as well as one that's being developed by my group called Take Good Care, that's targeting alcohol use in youth with chronic medical conditions. These are all under development or about to be, or in field trials, or in manuscript preparation phase. And these are certainly just a handful of interventions that I'm aware of. When it comes to interventions in development, I'm certain that there are many, many more that are not listed on this slide. I just would like to conclude with some summary thoughts that I hope will be a transition into the next section, which will be a discussion of how CTN and CSAT can partner together on these. I would say, in summary, about the in-person BIs is that all 3 of the models that have really been well described and studied have demonstrated efficacy. So there's really promise in brief interventions with adolescents. Depending on the study, we've seen reductions in alcohol, tobacco, and marijuana use, so that it's possible to target any of these substances. But what's been missing are more pragmatic trials, implementation studies, and comparative effectiveness trials. That's all really been needed because, in order to really get these studies out and see if they work as well in real life practices as they do in highly controlled study situations. For technology-based, I would say these are also promising. They're very practical given the low demand on provider time and their ease in scalability. But there's really been very limited exportation outside of trials, so even brief interventions that really look quite good have not really hit the primary care practices and the emergency rooms to date. And I think that the implementation studies here will be even more challenging because certainly all of these sites are becoming more and more having more and more access to computers and using computers for more and more different activities. But I don't think that they've really been used to a large extent for administering interventions. And so thinking about how to do that, I think would be some of the next steps. And I will stop there and thank you very much for your attention.
Great. Thank you so much, Sharon. And thank you to all of our presenters. This has been just a terrific panel, and there's just so many important points to follow up on. And I think, well, unfortunately, we only have about 8 minutes now, but I think that there's probably sufficient interest in this topic for us to figure out how to continue this dialogue among audience members who are interested in doing that. So why don't we open it up for questions, either questions to the speakers, any of the speakers, or we really want to talk about any ideas that folks have around collaborative opportunities between CTN and CSAT. Sharon's also brought up some important considerations around that. So I'll just open it up, and anyone feel free to jump in.
At this time, all lines will be open and unmuted. Please self-mute your telephone using the mute feature on your phone when you are not speaking to help prevent background noise.
So folks should be unmuted. I see we have a large number of audience members here, many of whom specialize in adolescent substance use disorders. So please feel free to make any comments or questions at this time. And so why don't we go to some of the questions that some of the presenters raised then. So Kim asked a question that it would be great to hear feedback on around, as you think about adolescent substance use disorder treatment, how do we think about intervention development in terms of developing interventions to fit with the current workforce or really rethinking our workforce delivery models? What do either speakers or audience members think about her question around that?
Well, this is Mark. I will say that we definitely have a gap. That's no surprise to anybody, but the workforce shortage continues to squeeze, I think, everybody around the country, and delivery models and reimbursement models that adequately incentivize training young people going into this field and the ability, as Dr. Johnson mentioned, to really step up the quality of treatment. Through training, through supervision, which is very difficult for us to know how to fund on Medicaid nickels. These remain challenges. I wish I had the answers, but it's an important question.
Yeah, I think for both questions about buprenorphine, naltrexone, and treatment for opioid use disorders, as well as brief interventions for treating tobacco, alcohol, and marijuana, I think the next steps really are thinking about scalability. There are a number of models. What's really impressive to me is that there are a number of models that have all had positive results in trials, and so there's a real basis, I think, that means to build on. And the next step is figuring out how do we actually deliver these to kids, and what are the I think we need to be looking at implementation and figuring out what echoing what Mark just said, thinking about how do we support the workforce in actually delivering these interventions that we know have been shown to work in trials. How do we go that next step? And I think that that's true both for buprenorphine and opioid use disorder treatment, as well as for brief interventions.
So we've heard so much today about the state of the science of adolescent substance use treatment, and there's still a lot of important research that needs to be done. But as we think about what we're talking about here today, how do we think about the intersection of the science and our service delivery models, right? So as CSAT's investing in adolescent services for substance use in the nation, what role could science play, including CTN play, in helping in defining best practices or evaluation, either at site levels, state levels, national levels? What kind of metrics would be important? How do we think about the intersection of these things?
It's hard to imagine how we could be nimble enough, but it sure is an aspiration that would be worth figuring out. If some of the community delivery enhancements that are funded by CSAT could then have more rigorous kinds of evaluations where we could have practice-informed evidence, about new innovations and delivery models, and have a reciprocal kind of collaboration between the researchers and the community treatment programs that at the state levels that get funded by CSAT. Boy, that'd be exciting. Don't know how to do it, but
it would be fun to think about how could we work with the CTN to do research with our grantees, right? So I don't even know if it's necessarily evaluation, but I think thinking about implementation research or using our grantees as sites, you know, I think that that's something that would be worth exploring. Because of our grant-making processes, we'd have to do something different, and I don't know if we can, but it would be interesting to try to figure that out.
This is Alan Budney. What I wonder about this sometimes is we're trying to implement things with a community that's not necessarily ready to change because they do what they do and they embrace what they do. And I wonder about how we present our results and our findings. When we talk about showing positive findings in trials, are they convincing to the average community provider or the administrator, and that our abstinence rates are always very low and our reductions aren't that huge? Is there enough data there to convince people that they really should change their system and use what we've shown in our clinical trials?
I think without the health services research that shows scalability, that shows sustainability in standard reimbursement models, we'll struggle. It remains a barrier. I think the answer to your question is no, we're not well digested. We're not well absorbed by a field that, as you say, is reluctant to change because delivery models and finance models drive practice.
Well, and is it worth it? I mean, whether we're talking about the medications or if we're talking about the behavioral interventions, I mean, most of them, particularly with this population, have a small or moderate effect size. And so when you're talking about the level of investment and change, you know, I mean, as a former agency director, it would be hard to at that level. Yeah, no, I think that these are all questions that need further discussion, and I think this is a great start, and I think we probably need to set up some more conversations, and I hope people will be willing to do that.
Yeah, that was great. Thank you, and I hope so too. And I love this phrase that Mark used of practice-informed evidence, because the opportunities to accelerate, I think, the scope and the pace of learning in this space would be terrific if we could figure that out. So thank you all so much for joining, and we would love to engage a subset of you in thinking about next steps in a future call. I just want to mention before we hang up, our next combined CSAT CTN webinar is going to be on Tuesday, December 13th. At noon, again from the 12 to 1:30 hour, and the theme of that one will be on pregnant and parenting moms with substance use disorders. Thank you all for joining. Take care. Bye-bye.
This does conclude today's presentation. You may disconnect.